Alright, hello, my name's Dylan. I'm going to be doing a cardiac assessment today. May I start this assessment by asking your name?
Kendra.
Nice to meet you.
You also.
Alright, within this assessment, I'm going to first ask what your family history is. Do you have a history of hypertension, heart problems?
My mother and grandmother have high blood pressure.
And do you have high blood pressure?
No.
No. Are you a physically active person?
Yes.
How would you say your diet is? High cholesterol, lots of fat?
Healthy for the most part.
Healthy for the most part, that's good. Alright, are you on any heart medications?
No.
And later on in the assessment, if they are on heart medication, such as a beta blocker, I'd want to, when I'm assessing their pulse, I'd want to listen, feel and count their pulse for a full 60 seconds. Have you smoked or had any caffeine within the past 30 minutes?
I don't smoke and no caffeine today.
Good. Good. I'm going to inspect the patient. And by inspect, I'm going to look for, could you look up? Relax your head to the right. I'm going to look for a jugular pulsation, which I'm not seeing. I'm not seeing any jugular distension either. So that's also good. Jugular distension could be a sign of hypovolemia. Jugular pulsation could be a sign of cardiac failure, more specifically congestive heart failure. I'm not seeing any cyanosis in the lips, and that'd be potential cyanosis when I see blue lips. As far as the hands go, thank you. I'm not seeing any clubbing of the fingers. I'm not seeing any edema or swelling of the wrist. Clubbing of the fingers would be when they become spoon-like. They're going to be really fat towards the end, like a spoon, like Martian fingers. I should check a capillary refill. Squeezing it, came back. Squeezing it, came back. Capillary refill should happen within less than 3 seconds. So that's a good sign as well. Thank you. I'm going to move on to the feet. And with the feet, as far as the hands go too, there's no edema. With this patient, there's no edema. Edema is going to be graded 1 to 4, 4 being the worst. What I'd want to assess too with that is whether the skin's smooth, shiny, and hairless. That could be a sign of inadequate blood flow. There's not enough nutrients and oxygen getting to that body part. And another thing, you'd want to assess whether the edema bounces back or not, whether it's pitting. And yeah, I'm not seeing it. So that's a good sign too. You're pretty healthy so far. What I'm going to assess while I'm down here though is I'm going to feel for the dorsalis pedialis pulse. And I found it. I'd give it an amplitude of 2. That's going to be rated. Amplitude for pulses is going to be rated 1 to 3. 3 being the greatest. Well, no, it's probably a 3. More, I'm holding my finger there. 3 would be bounding, to be the easiest to feel. 1 would be weak, thready, and there's also 0 for no pulse. I'm going to take your blood pressure if you don't mind. Alright, the cuff should be about 80% of the arm. I should be able to fit my finger underneath. And we're gonna pretend I just did that bilaterally too on both sides of the patient, inspecting and feeling the pulses. But thanks to COVID, this isn't exactly the ideal environment. I'm on a sofa. So yeah, we're going to pretend I don't know this patient. I'm going to pump it up to 180 millimeters mercury. I'm going to palpate for where the bradycardialis pulse is going to be strongest still before I put my stethoscope in a random spot. like 116 over maybe 74 around there. And that's within healthy range. 140 is going to be hypertension. 160 is going to be stage 2 hypertension, and 180 is going to be a hypertensive crisis. Probably wouldn't be conscious then either, or have like a pounding headache. There was no auscultatory gap either. An auscultatory gap with blood pressure is going to be when you hear it, maybe you hear it at like 160, it goes away and it comes back at 140. And it disappears at 80. That'd be a sign of vascular stiffness. And a lot of the patients at the nursing home had that. They had me off guard at first. Alright, so as far as the heart goes, I'm going to, well, you know what, I'm getting ahead of myself. Look up, relax, yep. I'm going to feel the carotid pulse with my fingertips because my phone has its own pulse. Yeah, it's bounding. Let me do the radial pulse, please. This one I'm going to count for 30 seconds. And I have 31 for that, so we're going to double that. That will be 62 beats a minute. So that's really good. I'd be happy with the resting heart rate like that. I should have mentioned that earlier too in the assessment. We're also going to inspect the patient to see if they're anxious. Their heart rate might be a little higher bradycardia, or if they're lethargic acting, heart rate might be a little slower. I'd rate that as a 3 bounding pulse. I don't think I listened to your carotid yet. I should have listened to it too. And what I'm going to listen for is any brutes. Ooh. And there's no brutes. A brute would be when the artery has a blockage, like plaque, and it shrinks. And now we're trying to send all this blood to this shrunken spot. We might hear like the friction, drop of like friction, and well, we could prevent probably a stroke finding that. Same thing with the high blood pressure. We'd be able to prevent a aneurysm, which would be a weakening of an arterial wall if I found high blood pressure. Now, next I'm going to listen to the heart, which I'm going to listen to the aortic valve, the aortic valve in the second intercostal space on the right side of the patient. Then I'm going to go to, I don't know if you guys can see this, then I'm going to go to the pulmonic valve on the second intercostal space on the left side of the patient. Then I'm going to go to Erb's point on the third intercostal space of the patient. The tricuspid valve in the fourth intercostal space, and the mitral valve in the fifth intercostal space of the patient. And I'm also going to listen for the apical pulse there. And I'm going to use both sides of my stethoscope to find any heart murmurs. And a heart murmur would be some offbeats, such as S3 and S4. S3 would be a ventricle, and S4 would be an atrial gallop, ventral gallop, ventricle and atrial. side for me, please. And I'm going to switch my stethoscope to the bell. The reason I switched my stethoscope is, well, murmurs are graded 1 to 6. 6 is going to be very loud. I might even be able to see it. I'm not gonna hear. My ears aren't gonna be trained for like a 1 or a 2. But yeah, the murmurs might have different pitches to them, so I'm gonna use both sides of my stethoscope to check for that. I didn't do the apical pulse yet though, and I would like to do that. And I can listen for 30. Should roll to the side a little more. I'm gonna listen 30 seconds for that. And I also happen to get 31 beats again, so that's good. There's no pulse deficit between the radial pulse and the apical pulse. There was a great deficit. Well, that could be a sign of an arrhythmia. Alright, so you're pretty healthy. I'm not sure what else I'm missing for a cardiac assessment. I think that's everything. And if she did have caffeine or smoked like a cigarette before this assessment, I have to wait like 30 minutes to do blood pressure and get an accurate reading. Alright, you sound hungry. Hope you guys enjoyed the assessment.